Welcome back to the deep dive. Today we are taking a fascinating and really humbling look into the human nervous system. We're zeroing in on spinal cord injuries, or SCI.
hmm
And for most of us, I think when we picture an SCI, we see that one single devastating moment. You know, a catastrophic car crash, a really bad fall, something like that.
And that initial picture is so important because SCI is, at its core, defined by trauma. It's what happens when vertebrae or, other objects are just violently forced against the spinal cord.
Crushing it.
Exactly.
Yeah.
Crushing nerve cells and basically blocking that electrical superhighway that runs everything.
And the spectrum of outcomes here is just enormous. I mean, you could be
Yeah.
looking at something that presents as relatively slight muscle weakness all the way to a complete irreversible loss of function.
That range is precisely why we're doing this deep dive.
Hmm.
Our whole mission today is to get inside that trauma and understand what really dictates the final outcome. We need to strictly distinguish between the primary injury,
The initial hit.
the initial mechanical hit, yes, and then the more insidious, delayed secondary damage. That's the biological chain reaction that really determines the patient's future.
And before we jump into all the complex wiring, let's just be really clear about the stakes. The sources we looked at are emphatic about the immediate signs, the things that mean you need to call for emergency help.
Right.
We're talking extreme pain or pressure in the neck or back, sudden weakness, paralysis, even subtle things like losing bladder or bowel control or having trouble breathing. If that cord is damaged, every second counts.
Okay, so let's unpack this incredible structure, the spinal cord itself.
Mhm.
If we're sticking with that highway analogy, what are the main routes it's handling?
It really is the grand central station of the nervous system. It connects the brain to, well, the entire body, and it's two-way traffic.
Okay.
You have descending pathways, which carry motor signals, so commands from the brain down to the muscles to make you move. And then you have ascending pathways carrying sensory signals.
Feedback from the body. Exactly. Feedback. Touch, pain, temperature, knowing where your joints are in space. All of that goes up to the brain.
And this whole precious cord is sheathed in the vertebral column, right? The protective bones cushioned by the spinal discs.
Yep. The sources break it down into 5 major segments, and you have spinal nerves coming out from each one, innervating specific parts of the body.
But I want to get into the internal wiring, the traffic control center, you might call it, the gray matter.
Yes, the gray matter is where the immediate processing happens. It's shaped kind of like a butterfly or an H, right in the middle of the spinal column.
Okay.
And the 2 key zones are the dorsal horn, that's the rear section, which is mainly for receiving all that incoming sensory information we talked about.
So all the feeling stuff comes in through the back.
You got it. And then, moving forward, you have the ventral horn.
And that's the doing part.
That's the engine of action.
Okay.
Exactly. The ventral horn contains the motor neurons that send commands out to control movement.
So when you zoom out, you realize that the axons, these really long nerve cell threads, they don't just stop and start in one little area. They have to travel the whole length of the spinal cord to connect to the right nerves.
And that is the crucial vulnerability. An impact way up in the neck, in the cervical spine, it isn't just affecting that one neck segment.
Right.
It's crushing or tearing the axons of thousands of neurons that are just passing through that area on their way to the legs or the torso or the muscles you need to breathe. It's all packed in there together.
So it's an immediate systemic shock.
A total systemic shock.
Okay, so let's look at how this supposedly protective bony structure actually fails. The sources explain that most SCIs are caused by a sudden, just overwhelming traumatic force that distorts the whole vertebral column.
And we can actually break these down into specific mechanical forces. Think about hyperflexion. That's when the neck or back is violently bent forward.
Like in a car crash, a rear-end collision.
Exactly. Or you have the opposite, hyperextension, where the head snaps backward. Then there are compression forces.
That's the one you hear about with, like, diving into a shallow pool.
That's the classic example. The head hits the bottom and that force just drives straight down the spine.
Wow. And you also get rotational injuries and the most devastating one, transection, where the cord is actually severed.
And the leading causes just reinforce how common this is. Vehicular crashes are still number 1, followed by falls and then violence. We should also note the sources do mention other causes, like sports injuries or diseases like cancer or osteoporosis that weaken the bone.
So that brings us to the primary injury. That's the immediate hit, the mechanical catastrophe. What exactly is getting damaged in that one instant?
In that split second, you get bruising or tearing of the nerves. You have immediate damage to the tiny blood vessels, especially in that central gray matter we just talked about.
Oh, okay.
This leads to immediate neuron death and, really crucially, demyelination of the axons. That fatty sheet that helps the signal travel fast, it gets stripped away, the signal just slows down or stops right then and there.
And when you look at the data, is there a clear profile for who is most likely to suffer this kind of trauma?
Yes, the data is pretty consistent. It points to single adult men as the highest risk cohort. And when you look at the racial and ethnic data we analyzed, non-Hispanic whites have the highest rate.
But there's a shift happening.
A very important shift. We're seeing an increasing number of SCIs among older adults. And for them, simple falls are becoming the primary cause, which just reflects the general aging of the population.
Okay, here is where we hit the real core of this deep dive, and it's this counterintuitive idea that really changes everything about how you treat this, the final outcome.
Yeah.
It's often less about that immediate physical impact.
The primary injury.
Right. And far more about what happens next.
We're talking about the secondary injury.
Mm.
And you can really think of it as a biological ticking time bomb. This isn't one event. It's a chaotic chain reaction, a cascade that unfolds over hours and days after the initial trauma.
So wait, the immediate crush might kill, say, 10% of the nerves, but this cascade could kill another 40 or 50%.
That's it. And it is genuinely shocking.
What are the key elements of this internal meltdown?
Well, the first major factor is ischemia, which is just a profound reduction in blood flow. That initial crush damaged blood vessels, it caused internal bleeding and swelling, and all of that lowers blood pressure right in that area.
So the neurons that actually survived the physical blow are now just starving to death.
They're starving. The infrastructure's gone. And the gray matter, which needs a lot of energy, gets hit the hardest. Then you have the physical compression from swelling, from edema.
Right.
Anywhere else in the body, swelling is just annoying. But inside the rigid, bony spinal column, that edema acts like a vice. It just compresses everything and crushes the remaining healthy tissue.
But the part that always gets me is the body's own defense system basically turning on itself, the immune paradox.
It is the ultimate double-edged sword. Normally, you want immune cells rushing in from the blood vessels to clean up debris and fight infection. But in the super-sensitive environment of the central nervous system, this response is, well, it's highly toxic.
How is it toxic? What are the immune cells doing that's so destructive?
They release these incredibly potent destructive chemicals, things like free radicals and excessive amounts of neurotransmitters, which leads to something called excitotoxicity.
Wow.
This chemical soup, which is meant to clean up dead tissue, just ends up causing widespread destruction of the adjacent still functional nerve cells. It's basically biological friendly fire.
So the key takeaway for you listening is that modern emergency medicine, they're not just treating the fracture. They are racing against the clock to try and manage this hyperactive, destructive internal cascade.
Absolutely. The whole goal is to limit that edema, maintain blood pressure to get blood through, and control that inflammatory response in the first, 72 hours. That is the major therapeutic frontier. That is where you can make a difference.
When we shift to clinical outcomes, the physical level of the injury is just everything. The sources all emphasize the higher the injury on the spine, the greater the extent of the motor and sensory problems.
And it becomes a life and death issue really fast. Any injury at or above the T12 level, that's the lower thoracic spine, starts to significantly impact your respiratory muscle control.
So your ability to breathe.
Your ability to breathe, to cough, to clear your airway is all compromised.
Yeah.
And that tells you why airway management is always listed as the #1 priority in acute care.
Clinicians then classify these injuries broadly as either complete or incomplete. Let's start with the total loss. A complete SCI.
A complete SCI means a total loss of both motor and sensory function below the level of the injury. It's generally considered irreversible.
Oh.
But the fascinating diagnostic key here is the S4-S5 area.
Okay, why that specific area?
For an injury to be truly deemed complete, the patient has to have lost sensation in that S4-S5 area, which covers the anal and perianal region.
Why is that the absolute benchmark?
Because S4-S5 is the absolute lowest segment of the spinal cord. If function is gone there, it confirms that every single pathway from the brain down has been severed. It's the definitive sign.
So conversely, an incomplete SCI means there's some partial function left. You might see a patient who can feel something, but can't move much. Or the other way around.
Exactly. And these incomplete injuries often show up as very specific, sometimes bizarre-sounding clinical syndromes.
Right, and this is where the anatomy really matters.
It really does. Take anterior cord syndrome. The patient loses complete motor function, pain, and temperature sensation below the injury. But, and this is amazing, they retain proprioception and vibratory sensation.
So let me get this straight. They know where their limbs are, and they can feel a vibration, but they can't move them or feel if they're, say, burning themselves.
That's it. It shows that the anterior pathways for motor and pain were damaged, but the posterior columns, which handle those other sensations, were spared.
Incredible.
Or look at Brown-Sequard syndrome, which is often from something like a stab wound that only damages one side of the cord. Here, the patient loses motor function on the side of the injury, but they lose pain and temperature sensation on the opposite side.
So if you get hit on the right side of the cord, you can move your left leg, but you can't feel pain in it, while your right leg is paralyzed, but you can feel pain.
That's exactly right. And because the injury is so focused, the prognosis for recovery in Brown-Sequard is often considered pretty good compared to other syndromes. It's powerful proof that the specific nerve pathways damaged directly dictate the outcome.
So moving into management, the acute care priorities are pretty stark. You said maintaining the airway is number one. What comes right after that?
Preventing any further movement. You have to immobilize the spine immediately. This means using things like a hard cervical brace or sometimes even spinal traction or what's called a halo brace for certain cervical fractures.
And all during this time, the medical team is just fighting to keep the whole system stable, prevent shock. They're running constant tests, including ABGs, arterial blood gases, to check oxygen levels, and of course, the neurological exam.
Right, and the gold standard for that is the ASIA standard, the American Spinal Injury Association. It's a standardized scale that doctors use to rigorously test key muscles and the sensory points. It lets them precisely map out the injury.
It gives everyone a common language.
A common language for prognosis and for tracking any progress.
Looking ahead, though, an SCI patient's life is often about managing really serious long-term complications. It sounds like it's less about treating one injury and more about managing a whole new baseline of systemic vulnerability.
That is a perfect way to put it. The loss of nervous system control just causes widespread systemic breakdown. Take the cardiovascular risks. They face something called autonomic dysreflexia.
That sounds terrifying.
It is. It's a life-threatening situation where the autonomic nervous system just overreacts massively to some stimulation below the injury, causing a huge, potentially fatal spike in blood pressure. It can cause a seizure or a stroke, just like that.
And DVT, blood clots, that's a constant threat from being immobile.
Correct. And systemically, you have major respiratory issues, like pneumonia. We have to talk about skin health integumentary issues, because sensation is gone, pressure sores, burns, cuts. They become a daily high-risk problem.
And of course, the elimination systems are disrupted, so UTIs, kidney stones, and then there's the mental health component, the grief and adjustment to such a massive loss of independence.
Which brings us to rehabilitation. And that is a marathon, not a sprint. It takes a huge team. Physical therapists, occupational therapists, rehab nurses, and a specialist physician called a physiatrist.
Okay, physiatrist.
Yeah, that's a doctor who specializes in physical medicine and rehabilitation. They lead the non-surgical management and the whole recovery plan.
So for patients who do have some lower limb function left, what does that recovery look like?
We see some amazing technologies, particularly gait training with a body weight support device. The patient is suspended, so they only bear a portion of their weight, and it lets them retrain muscles, gain stability, and practice walking safely.
It's all about regaining as much independence as possible.
That's the goal.
And finally, we loop all the way back to prevention. The sources really highlight this as a public health responsibility. Just simple steps can stop this whole cascade from ever starting.
It is the basics, but they save lives. Using seatbelts, having a designated driver, never ever diving into shallow water or above-ground pools, and using the right safety gear in sports.
This deep dive has really given us that crucial understanding we set out for. We've mapped the intricate architecture of the spinal cord, defined that initial devastation of the primary injury, and most importantly, we've seen the sheer complexity of that biological meltdown that follows, the secondary injury.
We've learned that the final picture isn't just about the trauma itself. It's about that subsequent chain reaction that dictates the difference between, a potentially recovering incomplete injury and an irreversible complete loss of function.
And that distinction is just foundational for all the care decisions that follow.
Absolutely.
So what does this all mean for the future? I mean, the sources make it clear that the vast majority of irreversible damage comes not from that initial impact, but from the ischemia, the swelling, and the body's own hyperactive, destructive immune response in the hours and days afterward.
So if the body is actively destroying its own functional neurons after the trauma, it raises the ultimate question for medical science, right? What are the next major frontiers in drug therapy or maybe cellular intervention to actually stop this secondary wave of destruction? And how might success there just radically redefine the immediate prognosis for every single spinal cord injury patient? That is the hope of all the research today.